Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for episode 2 of Emerging Strategies to Address Management Challenges in Dyslipidemia. I'm Dr. Scott Wright, joined today by Dr. Deepak Bhatt. In this podcast episode, we will be discussing guidelines and emerging evidence, as well as combination therapy as first-line strategy.
What are some lifestyle factors that can cause or worsen dyslipidemia? Smoking, choice A, obesity, B, alcohol consumption, C, or D, all of the above? Yeah, I think as most of you would indicate, it's all of the above, that smoking contributes to this, obesity does, excess alcohol consumption, and of course, what we didn't talk about, a diet that's high in saturated fat can also contribute to this. Well, this gives us targets for prevention. And now secondary prevention is something that we cardiologists do a lot of, because people who see us have established cardiovascular disease or established atherosclerotic cardiovascular disease, whether it involves the heart, the brain, the peripheral arteries, or they have symptomatic heart failure. And so we work aggressively to lower lipids, but by that stage, damage has already been done. Now, primary prevention is when you actually start intervening at younger ages to prevent these risk factors from promoting atherosclerosis development or to minimize its development. And that's when we're working on dyslipidemia, elevated blood pressures, diabetes control, metabolic syndrome reversal with weight loss, and sometimes metformin or, the newer drugs that allow patients to lose weight. And then primordial prevention is something that we should be working on at the global and individual national level. Improving rates of tobacco control or less smoking, reducing high caloric diets, promoting more physical activity and less inactivity, helping individuals lose excess weight, whether it's through diet, exercise, or the use of a GLP-1 or a multi-hormonal agonist therapy like Ozempic or Mounjaro. And of course, things like environmental pollution. And I think as we transition a bit away from vehicles that emit small particulate matters, we will see a huge drop and likely in the development of atherosclerotic disease. I remember poignantly reading an article in The Lancet some time ago showing the presence of coronary artery calcium scores was directly related to the distance population studied lived to major expressways where there was lots of smog or to coal-powered power plants. In St. Paul, Minnesota, about 70 miles north of where I am tonight, of course, in Manhattan, where Dr. Bhatt is, Los Angeles, as well as other cities around the world, all showed a penetration. The closer one was to those environmental pollutants. Well, the treatment goal for reducing risks, whether at the primordial, primary, or secondary prevention, is to do a risk-based approach. And there are a couple of ways to approach this. The first way is to say, I'm going to score everyone using the European scoring system, and they make it easy. A score of less than 1% is a low-risk individual. A score of 1 to 5% is a moderate-risk individual. A score of 5 to 10 is a high-risk individual, or a score greater than 10 is a very high-risk individual. The ACC recently published a consensus document making it even simpler. You can use coronary artery calcium. For example, a score of 0 makes you low risk, a score of 1 to 99 makes you moderate, and a score of 100 or more makes you high risk. In addition, as Dr. Bhatt alluded to in his opening comments, having multiple risk factors or the presence of disease plus 2 or more risk factors makes you very high risk. This is how I practice in a very simplistic manner. I now tell my patients, and I see mainly adults, so I don't see children, but I see adults. I tell them the new LDL threshold for everyone is less than 70. Now, if they're under 40 years of age, I'll use less than 100. But for almost everyone in my practice, it's 70 or lower. And for those who are returning from a either a hospitalization for an acute coronary event or complex revascularization with multiple risk factors, then the LDL target is 55 milligrams per deciliter or lower. So if you were used to practicing with old guideline thresholds of 130, 170, drop them all by 30, and that'll bring you into the new range. The ACC guidelines with regard to treatment make it really very simple. If your patient's at very high risk, they should be started on a statin, preferably a high-intensity, high-potent statin like rosuvastatin 20 or 40 or atorva 40 or 80. I recommend 40 as a starting dose for atorva in this country because 80 is not an FDA-approved starting dose, but you can titrate up from 40 to 80 pretty quickly after that. And then if they cannot achieve the LDL target that you're aiming for, whether it's 55 or 70, then the next line of therapy really should be ezetimibe because like statins, ezetimibe is now generic and our patients can be covered for less than 50 cents a day for these therapies. If the patients are older, I think it's reasonable to also use high-intensity statins, but if you're concerned about muscle side effects or if they're having weakness from other medical conditions, maybe you start with a medium-intensity dose like Rasuva 5 or 10 or atorva 20, and you may want to then combine that with ezetimibe. But I don't let age really block my desire to prescribe statins and other therapies to bring LDL down. I tell patients, if you have a life expectancy of 3 years or more, then you need to be treated because a stroke, for example, at age 85 is a terrible thing to have. And it's a terrible way to end life. So, we do see benefits from lowering lipids, not only for heart disease, but also for stroke and other things. Now, if your patient's at very high risk, meaning a target LDL of 55 or lower, you're going to have to really just prepare the patient and yourself to use multiple medications. Because if I have to lower the LDL, let's say 50 or 60 or 70%, you often have to use multiple pharmacologic agents. And then if we cannot get to a goal fairly quickly and readily with two oral medications, I'm quick to escalate these patients to a PCSK9 therapy, whether it's evolocumab, alirocumab as injectables every 2 weeks, or inclisiran as an injectable 3 times in the first year and then every 6 months thereafter. All of these therapies are reasonably cost effective when you look at long-term results and long-term data. The ones that are, of course, generically priced are the most cost-effective, and the PCSK9 drugs and bempedoic acid are certainly the least cost-effective, but they do offer benefit and do max out in the cost-benefit ratio. So the strength of recommendation for all of this is listed by color coding, but that's really what I do in my practice. And Dr. Bhatt, I'll ask you, do you do something similar or do you have a different style of how you manage patients?
My style is virtually identical to what you do. And in fact, very much in line with this algorithm as well. I mean, I'm a big believer in aggressive LDL lowering. I guess, not to quibble over numbers, but, versus the 55, I just tend to go with 50 just because I think it's a nice round number and easy to remember for the very high risk patients. But pretty much in every other way, my treatment patterns are 100% aligned with yours.
Excellent. I don't know about you, but if my patients are on 3-drug therapy and their LDL turns out to be 30 at the next visit and they say, is this too low? I say, heavens no, let's keep it there. It's more benefit. What do you do if it gets really low?
Oh, again, I'm 100% aligned with you. I, will reassure them that at least from the clinical studies that have tested such patients, at least for the duration of follow-up, typically of a few years, it seems really safe to have a pharmacologically achieved LDL that low. And chances are, if I'm starting them on that type of aggressive LDL cholesterol, it means because they're at really high, short, and intermediate term risk of an atherosclerotic event. So the risks are justified. And any theoretical risk is certainly justified by the benefits. And in terms of theoretical risks, while we don't have decades of, potent pharmacotherapy and seeing what the safety is, we do know from the natural experiments it seems quite safe. That is, patients with PCSK9 mutations seem to be quite healthy. They're able to live life normally. They're able to get pregnant. They're able to exercise. There doesn't seem to be premature dementia or anything. So they seem to be just fine line with that lifelong low LDL cholesterol. And likewise, at least in some less urbanized populations in the world, historically, places like sub-Saharan Africa, very low LDL seem to be quite safe. And as I alluded to earlier, newborn babies, typically the LDL is around 20-ish or 30-ish or so, and they're able to form brain tissue and retinal tissue just fine and grow. So, I think in an adult, an LDL in that level or even significantly lower is just fine.
Thank you. I completely agree. And I think people forget, because we practice largely in urbanized areas, that individuals who live in lesser developed countries or less economically developed zones often, and who do not have the access to protein and fat foods that we get, have naturally occurring LDLs of 20, 30, or 40. They grow old, they reproduce, they achieve amazing things, and it just doesn't seem to be a risk factor like we maybe was led to believe 30 years ago, that it might be a risk for hemorrhagic stroke. It's just really not. Well, I think we both agree that statins are the first line of therapy. Other generic therapies like ezetimibe are great second lines. You have now another choice with the PCSK9 drugs and a fourth choice with bempedoic acid. And this, of course, is all done on top of lifestyle modification between weight loss, eating a diet that has the right balance between polyunsaturated fats and protein and reduced carbohydrates. And then, of course, intensive lifestyle efforts with regular repetitive exercise, not periodic, but regular and repetitive, as well as cessation from exposure to more toxic things, whether it's, staying out of environments that have a lot of smoke, secondhand smoke, or other things. It's very important, I think, for us to really focus a lot on primordial prevention over the next 50 years. And I think you'll see more and more emphasis with that, where society tries to build in natural health promotion activities, more staircases, more walking in city centers, less use of particulate matter generating transportation means, and then aggressive early primary prevention in people in their late 20s, early 30s, for the rest of their life with regard to management of diabetes, dyslipidemia, hypertension, metabolic syndrome, and then very targeted aggressive reductions in those disease issues when they reach beyond middle age. Remember that the LDL particles contain 90% of the circulating ApoB, and that this is the major atherogenic particle that our patients are exposed to and that we need to treat. And the most reliable way to reduce LDL particles containing ApoB is to remove the LDL through the removal by upregulating on the surface of the liver this receptor that clears it from the body. And whether you use statins or PCSK9 drugs to achieve that, or both, is not as important as doing it. And using ezetimibe to target the inhibition of cholesterol absorption from food in the proximal small intestine, which results in the liver shifting more cholesterol into bile so that the bile concentration of cholesterol goes up. And it does that at the expense, or thankfully at the gift of removing cholesterol from plasma and shifting it into bile. And bempedoic acid also inhibits the de novo synthesis of cholesterol, and thus by doing so, reducing that intrahepatic gradient results in the expression of more receptors on the surface to clear the LDL. Again, this is just a reminder that if your patient has a need for treatment, that a high potency statin at the highest tolerable dose is the way to start. And then if they have achieved the LDL goal, whether it's 50, 55, 70, or 100, and they've achieved it, you're good. If not, you need to think about ezetimibe. And if they have not achieved it with ezetimibe, then a PCSK9 drug or bempedoic acid would be appropriate. And I think for almost all the patients that we see, using a PCSK9 drug is much more effective at achieving a very low LDL cholesterol. And these are in patients both for secondary prevention in high-risk situations, as well as in high-risk primary prevention patients, such as those with maybe early onset diabetes and high lipids, or even heterozygous familial hypercholesterolemia. The Odyssey study was one of the best outcome studies to evaluate aggressive PCSK9 use in patients with a recent acute coronary syndrome. Now, to enroll in Odyssey, you had to be on a high dose of a high-intensity statin, a torvastatin or rosuvastatin, and then have an elevated LDL despite that. So these were patients who had generally genetic dyslipidemias, and they were then monitored and treated for up to 4 years with either alirocumab on top of this high-dose, high-intensity statin or placebo given every 2 weeks for the duration of the trial to achieve an on-treatment LDL of less than 50 or at least a 50% reduction in the plasma LDL. And you can see that initially, patients had an LDL of around 90 to 100 who were randomized in Odyssey outcomes. Those all randomized to alirocumab versus placebo had very robust, very quick reductions in their LDL cholesterol that were sustained. You can see that there was a little bit of a creep up, back toward a little higher number from an initial nadir of 37.6 to an on-treatment low of 53.3. I don't know exactly why this happened, but it likely had to do with statin compliance, plus the little-known fact that the statins may upregulate the synthesis of PCSK9 a little bit, and that may have attenuated just ever so slightly the LDL lowering of alirocumab. Hard to say, just some hypotheses there. But there was a almost 50 milligram per deciliter reduction between placebo and alirocumab groups, or a 54.7% reduction. And you can see that over a very short time frame, 4 years in total, but even at 2 years, the curves were widely separated with an absolute risk reduction of almost 2% there, 1.5% to 2% at 2 years. And then by 4 years, about a 3% or so absolute risk reduction, maybe a little less because the number needed to treat was less than 50. It was 49 for the 4 years. But again, this was on top of maximally tolerated high intensity statin therapy. And there was an additional benefit to further lowering LDL with a PCSK9 drug. Early initiation of PCSK9 after myocardial infarction is supported by this trial, Odyssey Outcomes. It's also supported by, I think, the Fourier trial, because a number of those patients that had a recent acute coronary syndrome. And, in the hospital, we recommend starting high-intensity, high-dose statins, and then starting, I think, a PCSK9 as soon as you can. In my hospital, we get a lot of pushback at starting the PCSK9s before they leave the intensive care unit or the telemetry unit. But I think it's a good idea to do that. Now, this is as part of sort of guideline-developed medical therapy. In addition to, percutaneous revascularization with good drug-eluting stents, these patients need to be on dual antiplatelet therapy, and they also need to be on other medications, including ACE or ARBs and beta blockers to optimize blood pressure, and on SGLT2 drugs or GLP-1 plus SGLT2 drugs, along with metformin, to really optimize glycemic control. So there is not a single one shot or one fix for patients with ACS. It is a comprehensive approach to the clinical management of all of their risks. Now, the Evolve-MI study is a very interesting study that's ongoing at the moment. This is actually taking patients who are hospitalized for either ST elevation or non-ST myocardial infarction. They're on usual clinical care, which will likely mean high-intensity statin plus or minus ezetimibe, plus dual antiplatelet therapy, plus likely recent revascularization with one or more drug-eluting stents, and ACE and ARBs, plus optimal diabetic control. So on top of that, they will then be randomized 1-to-1 to either evolocumab or routine clinical care with a sample size of 2,000 patients per group, and then followed, as you can see, for about 3.5 years. And the evolocumab is dosed within 10 days of the index MI, and they're getting home delivery and self-administration of the drug. And what I really like about this study is that it's a pragmatic design. It's meeting patients where they are. And what they're typically doing. It's not like a true placebo-controlled trial where everything is held firm, but usual care is usual care. And then they do pragmatic data collection through what they can gather out of the electronic health record. And then if necessary, they can do e-case report forms and national registries to further the accuracy of the data. So I can't wait to see this data come out. I don't believe we're participating in this study, but Dr. Bhatt, are you all at Mount Sinai doing the study?
Yes, in fact, a couple of us are involved in it just on the executive committee, myself included. So I'm super excited about this study. I think it'll be broadly applicable to NSTEMI or STEMI patients. In fact, in Odyssey, you mentioned the trial before, the executive committee, or at least the majority executive committee, really wanted to start the therapy in the hospital, but for a variety of reasons, it ended up that that wasn't the final design. So that remains a bit of a gap. It certainly is the case from small studies that it appears to be safe to start PCSK9 inhibitors in the hospital after an ACS, but whether there's incremental efficacy versus just seeing them back in the office a month later and starting it then, hasn't actually been proven in a large outcome trial. So we'll see if there is incremental benefit from this approach. At a minimum, hopefully it'll confirm the safety. And at a minimum, I think it will likely lead to greater adherence to start the therapy in the hospital. I think generally speaking, that's true, that patients that are started on therapies when they're sick in a hospital are more likely to continue them as opposed to when they're started when they're feeling great.
That's so true. I think we know that from the early trials that Greg Fonero and I both published on with statins, showing in-hospital administration results in better LDL control. And I did a registry study showing reduced clinical events were reduced even by time of hospital discharge. It was an associational study, but a fascinating observation. Greg and I published then from the National Registry of MI a similar observation. It's been shown with heart failure therapies, and I'm with you. I think it would be nice to start all of these therapies in hospital because it's a teachable opportunity for our patients because they've had a life-threatening event. They're very open to learning. Their commitment to change is quite high. They're not contemplating it anymore. It's whatever they've been doing didn't work, so now they're ready to change. And I think the biggest obstacle is that the hospital does not want to take the financial hit of the cost of the medication because they get a fixed DRG payment for the Medicare age patients. And I'm not sure, probably many private insurers do the same. And so they're hesitant to really give us the flexibility. But that's a pity because really what's optimal for patient care is to get them started, help them learn how to do the first injection in hospital, whether it's a PCSK9 monoclonal or inclisiran, because I think once we show them how easy it is to take these agents, the adherence will be higher and the ease and the comfort of doing it is certainly much higher.
Agree.
Let's talk a little bit about bempedoic acid. It's had two really nice studies presented by Steve Nissen and colleagues recently at ACC in 2023. It's a drug that it's a citrate lyase inhibitor. It works about 2 steps or so before the HMG-CoA reductase step in the cholesterol biosynthesis pathway. It's not as potent as a statin. Surprisingly, working upstream from the statin, it only really drops LDL 15 to 25%, as opposed to statins, which are very potent, 40, 50, 60% reduction. So the CLEAR study was a trial of patients who were 18 to 85, had evidence of atherosclerotic cardiovascular disease and had proven statin intolerance. So they had to show that they could not tolerate 2 or more statins, one at a low dose, and still have an elevated LDL of greater than 100. They excluded individuals who had high fasting triglycerides, so greater than 500, in part because that population is at very high risk because of the triglycerides, and also in part because it makes the calculation, the indirect calculation by the Friedewald equation, just incorrect in terms of the LDL. They also, if you had a major cardiovascular event, a TIA or unstable arrhythmias, in the last 3 months, you were not eligible. History of severe heart failure or uncontrolled hypertension or diabetes mellitus. So if you didn't have those exclusion criteria, you'd have been randomized 1-to-1 to placebo or bempedoic acid. They enrolled about 14,032 patients and then followed them for nearly 3.75 years, looking at a primary endpoint that was combined, including cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization. And you can see that the endpoints were reduced, whether they studied a 4-component MACE endpoint as the primary endpoint, their traditional 3-component MACE endpoint, death, non-fatal MI, and reinfarction, fatal or non-fatal MI, or the need for coronary revascularization. So in these nearly 14,000 patients who were statin intolerant and at high risk, treatment with bempedoic acid was associated with a 13% relative risk reduction, or about a 2% absolute risk reduction compared to placebo treatment. Now, bempedoic acid was well tolerated. There was some concern about gout, and the incidences of cholelithiasis were also higher in those on bempedoic acid. So perhaps a bit of caution in patients who have pre-existing gout or high uric acid levels or have a lot of gallstones. But outside of that, I think it's a very safe drug to prescribe and use. Let's move on to a drug that I've worked very closely with since about 2016, which is inclisiran. Now, inclisiran is a small interfering RNA designed to work specifically in the hepatocyte or the cell of the liver to disrupt the translation of the message RNA, which codes for PCSK9 and produces the PCSK9 protein. So treatment with inclisiran really inhibits the PCSK9 protein. So how does this drug work, and how does it just get taken up into the liver? Well, inclisiran is a small double-stranded RNA that has a sense and an antisense strand for the message RNA of PCSK9, and it has a carbohydrate moiety attached to it called N-acetyl-galactosamine, or GalNAc. And the GalNAc moiety, or carbohydrate moiety, allows the delivery of this double-stranded sense and antisense strand to the hepatocyte because it binds exclusively with the ASGPR receptor. Now, this is worth remembering just for a moment because you're going to see a lot of therapies for lipids like LDL and lipoprotein A, therapies for hypertension if you're trying to disrupt renin, and therapies for liver disease all use GalNAc to deliver the drugs to the liver through the ASGPR receptor. That's a well-preserved receptor over almost time immemorial that allows the delivery of these therapies. Now, once inclisiran is taken into the cytoplasm, the sense and antisense strands separate, and the antisense strand binds something called the RNA silencing compound. And the RNA silencing compound was discovered in 1999 by a scientist in Massachusetts, and he was awarded the Nobel Prize, he and his team, I think 2004 or 2005, for discovering this silencing compound. And using the antisense strand, it binds complementarily to the PCSK9 for the mRNA of PCSK9, and it really magnifies the disruption and destruction of that mRNA for PCSK9. Thought is that the risk activation with the antisense strand is activated 1,000 to 10,000 fold. So a very tiny dose has a very potent effect of disrupting the message RNA for PCSK9. And then it just totally disrupts the liver's making of PCSK9, not 100%, but maybe 70, 80, 85%. And by doing that, it allows the LDL receptor to have a prolonged lifespan on the surface of the liver. And as the hepatocyte makes more natural LDL receptors and cycles them out to the surface, the older receptors just stay there, and they all together bind more LDL and then internalize it into the hepatocyte, which also lowers the synthesis of cholesterol. So you see very low levels of cholesterol achieved with very low doses of inclisiran given very infrequently. So that's the secret to how the small interfering RNA inclisiran works. This led to the development of the Orion clinical program that we started working on in 2016, I think, at the European Society of Cardiology. And then a number of studies have been published since then: Orion 1, Orion 3, Orion 5, Orion 9, 10, and 11, Orion 7 we published some time ago, and now Orion 8 has been submitted for publication. And all of these studies really looked first and foremost at the safety of inclisiran and then tested its efficacy in patients with elevated lipids. And it's been tested in a variety of patient groups, including in the pivotal phase 3 trials, 9, 10, and 11, looking at patients with heterozygous FH in Orion 9, established ASCVD in a U.S. population in Orion 10, and in an ASCVD or a risk equivalent population in Europe, including some sites in South Africa. Orion 4 is now the world's largest ongoing study with inclisiran. It's an outcomes trial building upon all of the phase 3 trials that we've talked about. Well, here's the study design for the Orion 10 and 11 trials. Remember, Orion 10 and 11 tested the LDL lowering of inclisiran across an 18-month placebo-controlled test. So patients with elevated LDL cholesterol who were on maximally tolerated oral lipid-lowering therapy. Most of these patients, almost 90%, were on statins, about 8% were on ezetimibe, and a small number of them were truly statin intolerant. And 2 out of 3 patients on a statin were on high-intensity statins. And despite that, they continued to have elevated LDLs of greater than 70 milligrams per deciliter, in many cases above 100, and they were randomized 1-to-1 to inclisiran 300 milligrams versus placebo. And they were followed for 18 months with injections given on days 1 and 90, and then every 6 months thereafter, with the primary endpoints being LDL reduction at day 510, and then control or area under the curve in terms of degree of reduction between days 90 and 540. Orion 11 was an identical design, same endpoints. The population in Orion 11 included 85% patients with ASCVD, and about 15% of patients had risk equivalents. What we saw in Orion 10 and 11 were very potent and durable reductions in LDL compared to the placebo-controlled patients. We saw a 58% reduction in Orion 10 over at day 510, and then a time average reduction of 56%, or area under the curve reduction of 56% in those randomized to inclisiran versus those randomized to placebo. So very potent lowering in a U.S. population with ASCVD. Orion 11 showed a 54% reduction in LDL cholesterol to those randomized to inclisiran versus placebo, with a time average reduction of 50% between days 90 and days 540. So again, both trials showed that infrequent administration of inclisiran, meaning giving it on the first day and then at 3 months or day 90 as a bit of a booster, and then every 6 months thereafter, resulted in sustained LDL reductions with the infrequent dosing regimen. As I mentioned a few moments ago, the Orion 4 trial is an outcomes study, which is taking about 15,000 patients or so who have known atherosclerotic cardiovascular disease and have had a history of a prior MI, prior stroke, or PAD, and they're being randomized 1-to-1 to inclisiran or placebo with a median duration of follow-up of almost 5 years and with a minimum duration of follow-up pre-specified in the protocol, looking at a combined primary endpoint coronary heart disease death, non-fatal myocardial infarction, stroke, or urgent revascularization. There are 2 additional studies with inclisiran looking at outcomes as well, the Victorian 1 Prevent and Victorian 2 Prevent. Victorian 2 Prevent takes, again, a high-risk secondary prevention population, again, 15,000 patients, randomized to inclisiran sodium 300 versus placebo and followed. You can see what the primary and secondary outcome measures are, very similar to almost all the clinical trials that we're testing in the cardiovascular arena. And then one that I'm very excited about as well is Victorian 1 Prevent, which is a primary prevention trial looking at patients without established cardiovascular disease, but with risk factors. There you can see the design. It's slightly smaller, 14,000 patients versus 15, with a primary endpoint of time to the first occurrence of cardiovascular death, non-fatal MI, non-fatal ischemic stroke, or the need for urgent coronary revascularization. And the key secondary endpoints are listed there. So taken together in totality, this is really the ongoing program to further evaluate PCSK9 lowering through inclisiran, a small interfering RNA, in, as you can see, almost 45,000 patients to look at both secondary and primary prevention. I think I've covered inclisiran and some of the other therapies pretty well, Dr. Bhatt. I'm going to turn it back to you and let you now take us to the next step about this.
Great. That was really a fantastic and comprehensive overview. I'm just going to touch on a few points here before we wrap up. And this is just to make the point that combination lipid-lowering therapy should be considered as a first-line strategy in very high-risk patients. And by combo, I mean statin and ezetimibe. In extremely high-risk patients, I really mean statin and ezetimibe and a PCSK9 inhibitor.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.